Hello, and welcome to our discussion of the management of a patient exposed to henipaviruses. I'm Dr. Susan McLellan, and I am the director of the Special Pathogens Excellence in Clinical Treatment, Readiness, and Education program at the University of Texas Medical Branch. And we support our Biocontainment Care Unit, which is a regional emerging and special pathogens treatment center for HHS Region 6. The Henipaviruses are a group of viruses that have only recently been identified in the last couple of decades. Medically important so far are Henipavirus and Henipaviruses, hence the name. These are RNA viruses in the family of Parexomyxoviridae, non-segmented, single-strand, negative sense RNA, and that's all the virology that I will give you. Important, though, are the reservoirs are the Pteropus bats. These are fruit bats. They're also called flying foxes in a lot of places. These are the really cute ones, if you even vaguely like bats. So where do we find these henipaviruses? So you look at this map and you're saying, oh, wow, they're all over the place. Well, that's not quite what the map is telling you. What the map is telling you is in the sort of reddish coverage is the distribution of the Pteropus bats that have been found to be infected with henipaviruses. Similar bats are found in Africa, and there has been some identification of henipaviruses of some sort in mostly just in bats, but in one case in humans, in Africa as well. However, in terms of human diseases with henipaviruses, we are talking primarily here for Nipah virus, which is the one that has caused the most number of outbreaks. And also in Australia is where we have seen Hendra virus in much more limited distribution in humans. So Hendra virus is one that has mainly killed horses in the east coast of Australia, but has been transferred to humans by direct contact with the sick horse. So far, there have been only 7 cases in humans with no indication of human-to-human transmission reported. It's manifested by encephalitis and respiratory failure. Case fatality rate is about 60%. So those who show disease have a poor outcome in the majority of cases. There is now a vaccine for horses available. There is monoclonal antibody product for humans in the works, and question of whether ribavirin could have some activity. But I'm going to spend most of my time talking about Nipah virus because this virus is one that has had a number of outbreaks, primarily in the area of most recently in Bangladesh and in India. However, it was originally isolated in Malaysia in 1999. The situation of transmission to humans was fairly interesting. So we know that these viruses are carried by these bats who are asymptomatic. And in Malaysia, the cases that were identified were in humans who had had contact with sick pigs and these relatively larger pig farming operations. And in fact, some cases were then transferred to other parts of the world because of the meat being transferred. However, the issue was the bats weren't giving it directly to the pigs. The bats were found to be eating fruit, as you see in the upper right, mango trees, associated with increased production of both farming of mangoes and of the pig farming in proximity. So the pigs were ingesting fruit that had been already in contact with the bats and therefore ingesting excretions from the bats, whether in the form of saliva, urine, droppings, etc., and so on. And so that is how the pigs were thought to have become infected. This resulted in culling of a huge number of herds and so on. However, this has not been repeated. Now, another difference is that there was no human-to-human transmission documented in Malaysia. I'm going to talk a little bit more about why that may be so as we move along. In 2001, an outbreak occurred in Bangladesh when this was identified and eventually identified as a separate strain, both on a molecular level as well as some differences in clinical presentation. The distribution and the transmission, I should say, into the human population in Bangladesh followed a slightly different path. This was found to be very much associated with consumption of date palm sap. And once again, the sort of ecological investigation indicated that what was happening was that during the collection of date palm sap, which is a sweet product used in beverages in these parts of the world and very commonly ingested. As you can see on the picture all the way on the right, there's a gentleman climbing up a tree, and he is placing a pot at the base of a number of scored slashes that he has made in the date palm tree for the sap to trickle into the bowl. And these pots are then left overnight. Well, as you can see from the adorable picture of the bat in the bottom left, the bats come at night and lick on these slashes. And while they're up there, they may urinate or defecate. That may get into the pot, or their saliva may get into the pot and therefore contaminate the sap. Other possibilities, of course, might be picking up a mango from the ground or some other fruit or anything else that could be contaminated with the excreta of these bats. As I said, very differently in Bangladesh, there was seen a lot more of transmission human to human. This still was close contact transmission. This virus does not seem to spread the way that, for example, SARS-CoV-2 does, with very easy aerosolized spread without close contact. The individuals to whom it spread were typically were care providers either in the home or healthcare workers. The other important thing to be said about these outbreaks that have occurred mostly in Bangladesh, but now some have also occurred in India and the Philippines, is that in the areas in which there has been transmission to healthcare workers are usually fairly low-resourced healthcare environments in which aggressive personal protective equipment was not available or was not standard or was not used because the individuals were not recognized to be infected with something that required it. So again, in Malaysia, the thinking is because the healthcare institutions were better provisioned, and also the standards of routine standard precautions that were in place may have been higher, may have been part of the reason for not seeing any human-to-human transmission. But there's another reason that has to do with the clinical presentation of these strains, and I will get to that shortly. This is just a quick sort of short version of reminding you of how people get this, whether it be Henipavirus, Henipavirus Malaysia strain, or Henipavirus Bangladeshi strain. The reservoir hosts are the bats. In the case of Henipavirus, horses have been the infected spillover host that then led to human infections. In the case of Henipavirus Malaysia, pigs were held that role. And in the case of Henipavirus in Bangladesh, the primary routes of infection appear to have been direct infection, typically, presumably of food products, causing human infection. So what should your procedure be if you are presented with the case of an individual who may be infected or has been exposed to a Henipavirus? Again, I'm going to focus on Nipah virus because that is the one that we have seen causing outbreaks. And because of that, the one most likely to be imported into an area in which people are not familiar with it. So lots of people have probably heard of the identify, isolate, and inform strategy that is very important to those of us who worry about the presentation of a special pathogen in an unexpected environment. I like to add to that a fourth I, which is initiate care, because it's vitally important not only that healthcare providers recognize a threat, isolate the threats, and inform the appropriate authorities, but also that they initiate care to the patient. So identify is the first challenge. Like many diseases, Nipah virus may present with a relatively undifferentiated presentation, and we're going to go through what that is in just a moment. But it typically includes potentially some respiratory symptoms and a relatively otherwise undifferentiated fever, malaise, headache, etc., and so on. This slide is general because I included generalized rash in here, which is not typically a presentation of the Henipaviruses. However, in general, all institutions should have some degree of wariness for individuals presenting with undifferentiated fevers, generalized rash, and or respiratory symptoms. And the important thing there is to ask about travel and exposure histories, because many of these pathogens that have specific exposures or specific geographic locations may not be thought of, much less recognized, if an individual has not asked about exposure history. So where, if somebody has traveled, where did they go? How long? What were their living conditions? What were they doing? Was there an occupation they were performing? Was it for fun? But either way, what were the actual activities that they were doing while they were there? And as consequence of, but very specifically, were they exposed to insects? Were they exposed to foods, in particular uncooked or unpeeled types of foods, animals or animal excreta, or ill persons or dead persons? So when you're talking Nipah, the where is, at the current point in time, going to be these areas of South Asia and Southeast Asia, where human transmission has been identified. And in particular, you want to ask if an individual was living in close proximity to local populations and close proximity to rural areas where these bats may be found in the trees and so on. And of course, what were they doing? Were they out there photographing bats? Were they exposed to insects? In the case of Nipah virus, were they exposed? Were they picking up fruit off the ground? With mangoes, for those of you that aren't familiar with mangoes and mango territory, the most common way to peel a mango is with your teeth, by biting into the edge of the skin and ripping it off. Obviously, if that is a mango that has been contaminated with the wrong bat excreta, that can pose a very high risk. Was the professional activity being a healthcare worker or visiting an ill family member? Were you in hospitals or attending to funeral preparations for persons who didn't survive an illness? Those would all be the type of things that one would pick up as considerations for Nipah virus exposure in that area, in that geographic area. So clinical presentation. So typically, as with many of our special pathogens, it's usually 4 to 14 days. However, with that Bangladeshi strain, there have been some delayed presentations up to 2 months later, and also rarely recurrence of disease. And we don't have a really good understanding of how that works and who's at risk for it, but it has been documented. Now, primarily, that has been recurrence of a neurological disease, and we'll get back to why that matters. Now, the symptoms are relatively abrupt onset of fever, headache, potentially vomiting, and then progression to encephalitis with or without respiratory failure. Now, of note, the Bangladeshi strain seems to have a higher likelihood of significant respiratory failure, and that includes having copious secretions, cough and copious secretions, saliva, nasal secretions, and so on. The fact of that increased amount of respiratory secretions may also be a contributor to the increased person-to-person spread that has been seen with Nipah virus in those parts of the world where the Bangladesh strain occurs. In both strains, encephalitis is the typical severe endpoint, which is likely to progress to death and manifest by altered consciousness, seizures, coma, and so on. So, what's the next thing to do? If you have identified this individual as risks for being a Nipah virus patient, the first thing to do is to put a mask on the patient as you start to walk them towards a single room to which you can close the door. If that's a negative pressure room, excellent, but if that is not available, move the person to a single room and get the rest of the history while the healthcare provider is in PPE and initiating care. So, what are the recommendations for PPE? Well, in truth, they're pretty much exactly the same as they are for viral hemorrhagic fevers, although the transmission to healthcare workers and person-to-person has not been as extensive as we have seen, for example, with Ebola. So what that means is that a stable patient without a confirmed diagnosis, it's pretty much your typical COVID protection, contact precaution, eye protection, and an N95 respirator. So same thing you can see people putting on there. Now, what does a stable patient mean? In the past, the terminology of a wet patient has also been used to indicate not producing a lot of secretions, such as vomiting, diarrhea, or extensive respiratory secretions. But an important point to be made, which has, I think, changed the terminology to stable patient, is that hemodynamically stable also matters, because a hemodynamically unstable patient is likely to require more aggressive interventions, and therefore, even in the absence of extensive bodily secretions, it is better to be more protected. So, in an unstable patient, somebody who has those secretions or is hemodynamically unstable, or both, then it's full viral hemorrhagic fever, PPE. In other words, covering all skin and clothing. So the recommendations are an impermeable gown or coverall, a PAPR with a shroud or an N95 with head and neck covering and a face shield, boot covers if it's not covered by your coverall, double gloves, and an apron. And those recommendations can be found on the website provided there, which is the CDC's Viral Hemorrhagic Fever Guidance. Next is inform. And really, hopefully, if you progress to the part where you're putting on that much PPE and worrying about whether this patient has Nipah, you are making a call to both infection control at your institution and to your local public health authorities. Those individuals can guide the decision-making tree about how high the risk is thought to be for any special pathogen. It's also a way to set the stage for a possible transfer to a special pathogens treatment center or RESPECT. Usually that's only going to happen once the diagnosis is confirmed. That may depend on your local strategy for handling persons suspected of a special pathogen. So the expectation, therefore, is that any institution may have to care for a patient, at least for the initial part of their evaluation and laboratory investigation. So that is the next important thing that has to happen, is to coordinate with local authorities for testing. Specimens are likely going to be sent to the laboratory response network facility, which your institution uses, or potentially directly to the CDC via the state. And again, your local health authorities will be able to guide you in that direction. They will also be able to guide you in appropriate packaging and how to send the specimen. Early in the disease, the specimen is going to be dependent on direct reverse transcriptase PCR, which may be from throat or nasal swabs, cerebrospinal fluid, urine, or blood, depending upon the manifestations that the individual is having and which specimens are available. Later in the course of illness, PCR may be less detectable and or antibodies may have developed, which can be used for testing as well. Again, that's going to be sent through your, with the assistance of your local health authority and probably through the LRN system. The next incredibly important thing is to initiate care. As the presentation is likely to be either encephalopathy or respiratory distress, or at the very least respiratory symptoms, thinking about respiratory, in particular ventilator support, is important. One of the things to consider is infection control issues with using high flow types of oxygen delivery, whether it be a high flow nasal cannula or positive pressure non-invasive ventilation such as BiPAP, because of the concern that those may allow more aerosolization of respiratory secretions. That may be less of a consideration if it's a purely neurological presentation, but again, those aren't the persons that need the oxygenation support. If it's looking like somebody may require intubation, it would be reasonable to consider early planned intubation in order to have a more controlled process, whether the individual is being intubated for respiratory support or for airway protection. Now, I'll mention that during the COVID outbreak, we've learned a lot about supporting people with viral respiratory diseases, and that early intubation may not always be the best strategy. We really do not yet have a good understanding of whether that is also true with Nipah virus. So that may be an ongoing discussion as to whether to go ahead and intubate somebody early or not, if the reason for intubation is respiratory support. Another important part of initiating care is laboratory support. It will be very important to discuss with your institutional lab their understanding of required infection control procedures to accept specimens, for example, to get your CBC or your chemistries, to your lab. Will they accept it at all? Do you have alternatives at your facility for point of care testing that can be brought to bear in a situation like that? If your facility does not have the capacity to get routine laboratory testing done for routine patient care, that would be a reason to consider transfer to an institution with a higher level of biosafety care preparedness in order to provide acceptable patient care. What about empiric treatment, especially if laboratory diagnostics are limited? One would consider what antibiotics might be appropriate. Is the person someone who may have been exposed to malaria? And if you don't have malaria testing available, do you need to just initiate antimalarials just in case? What about antivirals? Ribavirin has been mentioned as a possibility. Now, intravenous ribavirin is not easily accessible in the United States. As far as other antivirals, well, if the diagnosis still isn't clear and there's still the possibility that this is COVID or influenza, would one want to consider empiric therapy with antivirals? But that is often a clinical decision that needs to be engaged in, especially if the ability to do diagnostic studies is limited. Otherwise, care for the patient with a Henipavirus is primarily supportive. One would be thinking about the need for seizure medication if it was a neurological presentation, all the usual kind of pressor support types of things, and so on. There are monoclonal antibodies in development. Accessing any of these would only be available as emergency investigational new drug application, exclusively. That's a misprint there. That should say through the FDA, but also through consultation with the CDC and probably with your local special pathogens treatment unit as well, because somebody for whom you were going to be getting these kinds of investigational drugs would be somebody that one would be thinking of transferring to a special pathogens treatment unit. So what that brings up that's important is that in the process of initiating care, you are not alone. Even before a diagnosis is made, if there is concern for a special pathogen such as Henipavirus, go ahead and call for help. Always call your local health authorities first. They are likely to connect you with the CDC if there's significant concern for this. But you can also reach out to your local regional and emerging special pathogens treatment center. So each HHS region in the United States has at least one, if not more, respects, and their contact information is available through NETEC. And if you don't know what NETEC is, it's this, the National Emerging and Special Pathogens Training and Education Center. A great deal of information is available through NETEC, both on systems of care as well as pathogen specific and PPE specific and so on. So I hope you have enjoyed this presentation. As mentioned previously, I am from the University of Texas Medical Branch Spectre program. We are happy to share our information and our resources with you, whether you are part of our region or not. Thank you for your attention.